Hi, I'm Dr. Michael Brisman. I'm a neurosurgeon from Long Island, New York, part of a group called NSPC Brain and Spine Surgery. And I want to talk to you today about trigeminal neuralgia and facial pain. My specialty is trigeminal neuralgia and facial pain. And I do medical and surgical management, but it's important that we talk about things and that we get things right before we decide to go and do an operation, which is always the highest risk thing that we can do. So, the first thing about trigeminal neuralgia and facial pain is that I'll tell you that I see a lot of people with facial pain, and many of them that are referred for trigeminal neuralgia do not have trigeminal neuralgia. And of those who do have trigeminal neuralgia, they are usually not medically optimized, so I start with managing their medicines. So I'm usually not rushing into surgery with anybody. The first issue is the trigeminal nerve is the nerve that supplies feeling in the front half of the head. So it goes from the forehead, the eye, the ear, the nose, the mouth, the jaw. And there's a trigeminal nerve on the right side and the left side that supply feeling on either side of the front of the head. The back of the head is supplied by the occipital nerves, which come out of the upper cervical spinal cord at C2 and C3. So pain back there is not trigeminal neuralgia, and that's something else. So issue one is we want to know, is the pain that a person's experiencing what we call like nociceptive or neuropathic? Nociceptive is normal pain, pain that's conveying a message, like if someone is hurting you in your face or something's happening or you're touching something that's too hot or too cold, you would expect to feel pain. Things that could cause nociceptive pain might include dental disease, a cavity, a chronic sinus infection, chronic problem with your ear or your eye, and you would see appropriate specialists to assess for that. But that's the first thing to assess is the pain nociceptive or neuropathic? Neuropathic means there's something abnormal, that you're having pain when you should not be having pain, that there's something wrong with the nervous system, that you're experiencing pain when really you shouldn't be having any pain. So the next issue is to decide, is this trigeminal neuralgia or something else? There's a lot of information out there on the internet, among doctors, hospitals, and medical journals, and a lot of it is not correct. I've treated thousands of patients with trigeminal neuralgia, and I want to describe and discuss with you what is trigeminal neuralgia, because it's something very, very specific. It is a very specific type of facial pain, and people who have trigeminal neuralgia need to be managed totally differently than people who have other types of facial pain. In particular, people with trigeminal neuralgia neuropathic facial pain sometimes will benefit from surgery, whereas people who have neuropathic other types of facial pain usually do not benefit from surgery. So let's talk a bit about trigeminal neuralgia and what are the definitions and what make it up. And let me also say, I'm going to start by giving you definitions and terms that I think are not correct. About 20 years ago, a new classification came out where it was described a trigeminal neuralgia type 1, a trigeminal neuralgia type 2, and an atypical facial pain that are not correct, in my opinion, and I want to just describe that for a moment. In that description, anybody who had facial pain that was mostly intermittent was said to have trigeminal neuralgia type 1. And anyone who had facial pain that happened on its own, spontaneous facial pain, no other obvious cause, that was mostly constant, was described as having trigeminal neuralgia type 2. And anyone else, anyone who had some kind of psychiatric or mental disorder and had facial pain, was called atypical facial pain. This is just not right, in my opinion. Simply having facial pain that's either constant or episodic doesn't describe or define trigeminal neuralgia. And not surprisingly, many people who had facial pain who were described as having TN1 or TN2 and underwent trigeminal neuralgia surgery didn't get better. And it's no surprise because that is not trigeminal neuralgia. Furthermore, it is not correct that the only people who have facial pain and don't have trigeminal neuralgia are people with mental health problems. That's just wrong. I mean, a lot of people who have chronic neuropathic facial pain that don't have trigeminal neuralgia and don't have a somatoform or other mental health disorder. So I do not go by that. I wouldn't go by a lot of stuff that you see out there. So I'm going to tell you what trigeminal neuralgia is. It is critical to understand that the definition of trigeminal neuralgia is based on symptoms. There's no blood test. There's no MRI finding. This is based on what is the person experiencing. So here are the things that have to be there. Number one, it's a painful problem. It's not enough that it's tingly or itchy or something bothersome. The people must say it's pain. Number two, the pain has to be in the trigeminal distribution. That is to say, it has to be somewhere in the forehead, the eye, the cheek, the nose, the ear, the teeth, the cheek, the jaw, the lower teeth, something like that. It's got to be there. Next is the pain has to be sharp. It's not enough that it's a bad pain. It has to be sharp, and specifically, people will describe it as either electric shock or stabbing. But there must be a sharp pain. There can be other types of pain, but there must be a sharp pain component. The pain must also be intermittent. Now, people can sometimes say, I'm feeling it all the time, but if you ask them carefully, they'll say, well, it's all the time, but actually I'm getting these intermittent jabs of pain on and off all the time. But if someone says, I have just a sharp pain that's just nonstop and it's exactly the same, not fluctuating, that's not trigeminal neuralgia. It's an intermittent pain. It also has to be on one side of the face at a time. Now, people can sometimes have trigeminal neuralgia on both sides of the face, but not at the same time. So it should be on one side of the face. It also has to be, for any given time, in the same area of the face. People will say, I'm getting shocks in my cheek. I'm getting shocks in my jaw. Now, over time, months, years later, they may say, now I'm getting shocks in a different place, in my forehead. But for a given amount of time, there should be shocks of pain in the same area on one side of the face. The pains also have to occur, at least some of the pains these sharp pains have to occur suddenly. They have to be all of a sudden. Now, they can have some other types of pains, but they've got to have a sudden component to these sharp pains. The pains also have to be brief. At least the severe sharp pains, and it could last a second, it could last 15 seconds, it could last a minute, but this is not a pain that lasts at the same level of intensity for hours or days. Next is the pain. This has to be the main problem. Again, there could be other issues. There could be an achy or other types of pains, but the patient should tell you that the main problem is these sudden, brief, sharp, severe pains. Another issue is that these pains really should respond to trigeminal neuralgia operations, particularly if someone has had multiple such operations. Now, let's say a given trigeminal neuralgia operation works 70 or 80% of the time. It's possible someone could have trigeminal neuralgia, have an operation for trigeminal neuralgia, and not get better. But if somebody has a facial pain problem that you suspect might be trigeminal neuralgia, and they've had multiple properly executed procedures, and they still don't get better, it certainly raises a question as to whether they had trigeminal neuralgia in the first place. So those are features that really are like almost always there. Then there are other features that are usually there. Usually the pain is described as triggered. That is to say, it can be set off by a light touch, such as talking, chewing, brushing the teeth, a light wind. Something like that will all of a sudden set off the pain. Now, sometimes the patient will say, you know what, there's no specific trigger, it just comes on its own. But usually, most of the time, it's triggered. Next is, usually it's described as radiating. People will say, well, it starts in the chin and radiates back to the ear. It starts in the cheek and radiates up towards the eye and forehead. Usually, there'll be a radiating kind of component to it. They won't say it's suddenly all in the same part of the face. They'll say, well, it starts in one place and seems to zap to another place. Also, usually, it responds to the anti-seizure medicine carbamazepine, brand name Tegretol, or the very closely related uh, anti-seizure medicine oxcarbazepine, brand name Trileptal. These medicines are so effective that if a person is taking them and is tolerating them and is still not getting relief of pain, one does have to question whether this is trigeminal neuralgia or not. Now again, it's possible that they don't get better, but usually it responds to that. Now obviously it's different if a person takes a carbamazepine and immediately feels nauseous, they can't tolerate it, that's different. But if someone's able to tolerate it at a decent dose and gets no relief of pain, that does question the diagnosis. Also, usually or almost always, we will see remissions, spontaneous remissions. And what that means is that the person will say, you know what, there was a week, there was a month, there was a year when the pain just went away on its own and then it came back again. Now, obviously, if a person is just starting to experience the trigeminal neuralgia and they've only had it for a week, they may not be able to tell you about a spontaneous remission. But if a person's had it for months or years, I mean, almost always they will say, there have been, and you ask them, there have been days, there have been months, there have been years when I had zero pain. It just went away on its own. Other things that can exist with trigeminal neuralgia, and this is what I would call an atypical feature, is patients can have achy pains. They can have feelings of achiness, burning, other types of pains that are not the sharp, severe stabbing pains or electric shock pains. So they can have other types of pains, and they can have a constant component to the pain, which is achy. So there can be constant or achy pains, which I would get, again, this used to be called atypical trigeminal neuralgia, and I still call that atypical trigeminal neuralgia. That has some atypical features, but if the main component is still the sudden, sharp, brief, severe electric shocks or stabbing pain, then we say that person likely has trigeminal neuralgia. Other things that can exist, a person can have numbness in the face associated at times with the trigeminal neuralgia. Usually on exam they don't have numbness, but they can at times say, I feel a bit numb. Also, in rare cases, patients can have some autonomic features. Now that opens up a separate issue of trigeminal autonomic cephalgias. There are conditions where people have pain in the trigeminal area. They can have sharp, severe pain that are associated with autonomic features. Autonomic features include drooping of the eyelid, redness of the eye, tearing of the eye, redness of the face, drainage from the nose, swelling of the face, stuff like that. So the trigeminal autonomic cephalgias are severe pains in the trigeminal distribution, but what distinguishes them is they're mostly in and around the eye, and they have these autonomic features. Trigeminal neuralgia can also have autonomic features. So you can have that, and some people, myself included, believe that one of the categories of the trigeminal autonomic cephalgias, called SUNA or SUNCT, are just a subcategory, just a variant of trigeminal neuralgia. However, that does have to be distinguished from one of the trigeminal autonomic cephalgias known as chronic paroxysmal hemicrania, where people have severe, sharp pain in and around the eye with autonomic features, but the main distinguishing feature is these people do not get better from carbamazepine, and they get dramatic relief from indomethacin or Indocin, an anti-inflammatory medicine. And those patients should not be treated with surgery, and those patients do not have trigeminal neuralgia. So again, critical that we correctly establish what is trigeminal neuralgia and what is not. Because again, the facial pain is going to be treated very differently if someone has trigeminal neuralgia or not. What are the causes of trigeminal neuralgia? So there are certain common causes. Common cause number one is contact of a blood vessel against the trigeminal nerve as it exits the brain, or the part of the brainstem called the pons. And the part where it exits the brain is called the root entry zone, and that area is particularly vulnerable to compression or problems. The blood vessel that's usually going to be the culprit is the superior cerebellar artery, but other possible culprits include the anterior inferior cerebellar artery, the basilar artery, or a petrosal or trigeminal vein. But that's one cause, is a blood vessel contacting or deforming the trigeminal nerve. Other causes are multiple sclerosis. A certain percent of people with multiple sclerosis, maybe 2 to 4%, have trigeminal neuralgia, more likely to experience it at a younger age and more likely to have it on both sides of the face and somewhat tougher to treat. And another cause of trigeminal neuralgia is a tumor, often a benign tumor like an acoustic neuroma or meningioma that's contacting or pressing the trigeminal nerve, again, where it comes out of the brainstem. And then there are other, let's say, people who we don't really know what the cause is. Now, I would say that the only way you could really say that it wasn't one of the first categories is if a person actually underwent a surgical exploration. Because the problem is you can have a blood vessel contacting the trigeminal nerve and you could still not be able to see it, even with the best MRIs. Now, the MRIs we have now, particularly with the finer cut and Fiesta sequences, are pretty good at seeing a blood vessel touching the nerve, but not always. So I would say the assumption is that it's a blood vessel unless we operate, look, don't see anything, and then we may conclude, look, we don't really know what the cause is. What else can cause intermittent sharp facial pains? So one thing I already mentioned was chronic paroxysmal hemicrania, but again, that's pretty rare, and the tip-off is, again, that it's focused on the eye, around the eye, autonomic features, poor response to carbamazepine, and outstanding response to indomethacin. Another condition is post-herpetic neuralgia. If a person has a shingles outbreak in the face, and often this occurs in around the eye and the forehead in an older patient, afterwards a person can be left with a pain syndrome. These pain syndromes can have a component of intermittent sharp pain, although there's often a lot of burning, constant aching pain as well. And again, the key to understanding that it's this diagnosis is knowing that the pain started soon after a shingles outbreak in that same area. Another common cause of intermittent sharp pain is nerve injury. And there are a lot of things that could cause nerve injury, including procedures, including dental procedures. I mean, this is very rare, but those could cause a nerve injury, and a nerve injury could have some intermittent sharp pain to it, although often there's going to be constant achy pains as well. There may be numbness, and again, this should occur soon after the nerve injury occurred or the procedure occurred. Also of note, sometimes a nerve injury doesn't impact the exact area where the nerve injury took place. So it is possible a person could have an injury in one part of the face and a person end up with a chronic pain syndrome that's a little bit remote from that area. And then there's also a condition that is much rarer than trigeminal neuralgia that people should be aware of called glossopharyngeal neuralgia. The glossopharyngeal nerve is the ninth nerve, which supplies sensation to the deep throat, the tonsil area, and the deep ear, an area in the ear that's too deep to touch with your finger. If somebody has pains that are like trigeminal neuralgia in the glossopharyngeal, the ninth nerve distribution, then that is something called glossopharyngeal neuralgia. These people get sudden, brief, severe jolts of pain, electric shock or stabbing pain deep in the ear or deep in the throat, and that also can be treated with surgical procedures, but that's very rare, and that also needs to be distinguished from trigeminal neuralgia. And then there are other things we're not aware of why one might have intermittent sharp pain. And as I mentioned, it is possible to have trigeminal neuralgia on both sides of the face, but rarely at the same time, and that's more likely with multiple sclerosis. And but even people who don't have multiple sclerosis, about 5% of the time, people with trigeminal neuralgia who don't have multiple sclerosis will have it on both sides of the face, but at different times. We could talk about surgical treatments of trigeminal neuralgia. So first of all, with trigeminal neuralgia, we're usually going to be managing people with medicines first. Surgery is the last resort, not the first. Um, and many people will do very well on the medicines. And the first line medicines are usually carbamazepine and gabapentin. At higher doses, the carbamazepine can cause drowsiness, as can the gabapentin, and the carbamazepine or oxcarbazepine can also lower the sodium if the dose is too high, which can sometimes be mitigated by either lowering the dose or taking a little extra salt. But sometimes a person will have pain despite multiple medicines, or the medicines are just causing too much side effects like drowsiness, and then a surgical procedure can be considered. There are two main types of surgical procedures. One surgical procedure is the microvascular decompression. This procedure is done primarily when there is a small blood vessel contacting the nerve. This is usually going to be the superior cerebellar artery, but again, could be the anterior inferior cerebellar artery or ICA, or it could be a trigeminal vein. There are other blood vessels that can cause the problem. As I mentioned, the main one being the basilar artery, a large basilar artery, but a large basilar artery contacting or deforming the trigeminal nerve, in my opinion, is not a good case for microvascular decompression or MVD because it's just too high risk to try to move that artery away, and often it's not even possible. If there is a tumor causing the compression on the nerve or multiple sclerosis, I also would say that MVD is not going to be the treatment of choice. So MVD is really if the person has a superior cerebellar artery, ICA, or a vein against the nerve. And it's more likely if it to succeed and more likely to be the problem if it's an artery and more likely if the artery is deforming the nerve rather than just touching the nerve. Considerations are also going to be better if the person is under 65, younger, healthier, though theoretically it could be done for someone up to 70 or maybe even a bit older if they failed other treatments. The surgery itself is done under general anesthesia. Takes about an hour and a half to 2 hours. The incision is about 1.5 inches long. People have to stay overnight in the hospital, and there's small risks of bleeding or infection. But they're small, particularly in the hands of someone who does lots of such procedures. And I would mention, I think one of the reasons I can speak better to this issue is that I do all the treatments, the medical management, the MVD, the rhizotomies, the gamma knife, everything. Reasons that, again, the MVD is not going to be good is for multiple sclerosis. It's not going to be good if there's a tumor. It's not going to be good if there's a basilar artery as the compression. It should be rethought if someone has no hearing in the opposite ear. And the reason is that there's a tiny chance of hearing loss with the MVD. So if a person has no hearing or terrible hearing in the opposite ear, that would be something to lean you a little bit away from doing the MVD. Obviously, also, if the person is older or has serious medical problems, that also leans a bit away from the MVD. Another consideration that's rare is if on the imaging there happens to be a big bony overhang. Some people call this a large petrous endostosis, and there's a large bony overhang that obstructs the view of the nerve and artery. That could also dissuade a person a bit from doing the MVD. And the MVD is usually effective. Usually people use something called Teflon felt. It's a material that stays permanently and moves the blood vessel away. And more people are moving towards what we'll call transposition of the artery rather than an interposition. There's a concern that if the felt goes between the artery and the nerve and touches the nerve, that at some point the felt could itself expand, form a granuloma, and later cause compression and recurrence of symptoms. So more and more we're trying to, if we can, use the felt to push away the artery so the felt and the artery are not touching the nerve. And some people are using other materials as well, though the Teflon felt is the gold standard. The felt itself can cause a little bit of a reaction and can cause some headaches for 2 or 3 weeks, which is usually avoided by low dose of steroid, so I usually give my patients a little low dose of steroid for 2 weeks after this surgery. The other option besides MVD is to injure the nerve. And it's been known for a long time that you can eliminate the pain of trigeminal neuralgia by injuring the nerve a bit. This sort of breaks the cycle because we said usually the pain is triggered by a light touch, a light sensory input. So if we get rid of the sensory input a bit, that can eliminate the pain. And there are two ways of doing that, a direct or an indirect way. The direct way is by putting a needle into the nerve. This is done under sedation in the operating room. This procedure takes about half an hour. The needle is inserted an inch from the corner of the mouth into the cheek. It's inserted through a hole at the bottom of the skull where the nerve comes out, called the foramen ovale, which just means the oval hole. It's the hole where the third division of the trigeminal nerve comes out. The needle goes into that hole, and once it's in, can access all three branches of the nerve. And there are three ways of injuring the nerve with that technique. The radiofrequency, where we heat the nerve a bit. The glycerol, where we inject, which is an alcohol, where we inject a little alcohol in the nerve. And the balloon procedure, where we inflate a balloon against the nerve. I'm always set up to do all three, and I think there are different reasons why one might do one versus the other. The radiofrequency is my preferred technique if the pain is in the second or the third division, that is to say the cheek or the jaw, or both, because it can be selective and can injure just part of the nerve. The glycerol is better if during the procedure we access the cerebrospinal fluid, the clear fluid that bathes the brain, and if we get some of that fluid out the needle and we are in more like the trigeminal cistern, it's more favorable for injecting the alcohol, and we usually have the patient sit up for an hour or two afterwards so the alcohol sits on the nerve. And then there's the balloon procedure where we inflate a balloon. This requires a somewhat bigger needle to insert into the foramen ovale. The balloon is inflated for 60 to 90 seconds and compresses the nerve, and can also be good for getting all three branches of the nerve, but it's non-selective. And then one of the indirect way of injuring the nerve is with superfocused radiation. Usually we use a machine called a gamma knife. This is also like the rhizotomies, the needle procedure, is an outpatient procedure. It takes one morning. We put a helmet, a head frame on the head under sedation. Person gets an MRI, and then they lie in a machine, and focused radiation beams aim on the nerve for 45 to 60 minutes. It's painless. And then hopefully within a few weeks, the person starts to experience some pain relief as a result of that. The advantage of the nerve injuring procedures is they're outpatient, less invasive. The downside is more likely to have recurrences because the nerve can regrow, and also more likely to over-injure the nerve, which can cause either numbness in the face or achiness in the face. These symptoms usually improve over time as the nerve regrows, but not always, and it can take a while. It could take months or years for that to get better. That said, people are usually happy with any of these procedures if they're properly selected. If they really have trigeminal neuralgia, they've really failed the medicines, and they're miserable, then these procedures can be very effective and people can feel a lot of relief. Sometimes the procedures don't work, and then one could try another procedure. And sometimes the procedures work and wear off, and then a procedure can be repeated. I personally feel that the MVD is not good to repeat, except under exceptional circumstances, because the operation is much higher risk when one goes back in. So I think that's an operation best done once. I mean, it can be effective if you go back in, but often you're just injuring the nerve anyway by removing the scar tissue, so you're better off just doing it with a less invasive manner. The rhizotomy, the needle procedure, can be repeated an unlimited amount of times. The focused radiation can be repeated, but it shouldn't be repeated, in my opinion, for at least a year, and ideally 2, because you often don't see the full results of the procedure for quite a while. And then, again, if it's been a certain amount of time, you could consider a third or fourth treatment, but that should only be if that's a good amount of time has elapsed, because you don't want to over-injure the nerve. A critical aspect of treating trigeminal neuralgia surgically is not to cause harm, not to cause a complication, and one of the main complications that can be caused is over-injury of the nerve. You have to be very, very careful not to over-injure the nerve. And while I understand that patients really want to fix their trigeminal neuralgia and really want to knock that nerve out, we always have to go easy on things, because if we over-injure the nerve, you can end up with a new type of pain syndrome that's just as bad as the trigeminal neuralgia. People can complain they have terrible numbness, terrible pain, whereas if we don't injure it enough, we can always come back and do more. So while I'm sympathetic, and I understand why surgeons and patients want to really, teach that nerve a lesson, we don't want to. We want to do the right amount and not too much injury. When it comes, so I want to also mention, well, what do we do for people who have neuropathic facial pain that isn't trigeminal neuralgia? Let's say it's a constant achy pain, or it's something else. And there's a lot of people with that, and these patients should generally not be operated on. And very important to again assess, is this person someone with neuropathic facial pain that's not trigeminal neuralgia, because operating is just going to make things worse and subject people to risk that is not going to be useful. So there are a lot of things that we can do, even though it's not an operation, and there is cause for hope. First of all, sometimes these problems get better on their own. Next is, people need to understand that pain is often connected to depressed mood, to anxiety, to stress. Anything that can reduce any of those, including support groups, can be very helpful. Over-the-counter medicines like Tylenol and Advil are good. Hot and cold things can be applied. Sometimes topical compound pain creams rubbed into the affected areas can be helpful. Anti-seizure medicines can also help as well. Medicines like carbamazepine or gabapentin or Lyrica or other anti-seizure medicines. These medicines are not only good for dealing with the pain, but often medicines like gabapentin or Lyrica are very helpful because they make the pain or any problem less bothersome. And a good part of the problem is not just the pain, but the fact that it bothers us. Anti-inflammatory medicines can also be used, which include a low dose of steroids possibly, particularly if it's going to be for a short flare-up period. Non-steroidals, Advil, meloxicam. Their antidepressants can also be helpful, such as Cymbalta, Elavil, or nortriptyline. In some cases, we might even consider an intermittent marijuana gummy could be considered for a bad flare-up. Some people consider low-dose naltrexone. This is, again, kind of a way down the list after we've tried everything. And some people even believe that a few ketamine IV infusions might help break the pain cycle. There are a lot of things, though, that we can do for you, for patients with trigeminal neuralgia and with other types of facial pain. And it's important to seek out expert help and to understand that you are not alone, that people are there to try to help you with these problems. But again, I think getting the correct diagnosis and getting the correct treatments done in the proper way is going to lead to the best results. So me and my team and I, are always here to try to help you as best we can. And again, I think getting information and trying everything you can before an operation is always going to be best, but sometimes surgery can be very helpful. Thank you very much.